That means that we are trying to make the virus infect the host so that it can replicate within the host and infect that host. Now, some of them need help, some of them doesn't need help. Now, you need to know that the one that doesn't need help, it means that they can easily hijack the replicating mechanism of the host to their own favor. What are the replicating mechanism of the host? The host have some enzymes that are within them that can easily move nucleic acid from one form to another. How? They can move DNA to mRNA and they can move mRNA to protein. That's the normal thing that we do in eukaryotic cells. We've talked about that in our biochemistry, so that one is clear. Now, if a DNA virus that is naked, it doesn't contain its own replicating machinery, it's just the nucleic acid that is there. If it infects a host, now because of the fact that it's a DNA virus and the host contains DNA dependent RNA polymerase, they can easily convert it from the DNA to the mRNA. Then they can use the other machinery, the tRNA, the ribosome, and other things to convert it to protein. So once they synthesize the protein for the virus will now use that protein to form the capsid and other thing that will now surround that nucleic acid that is naked so that they can form a complete virion that will now infect that host. Is that clear? Do we get that?
Yeah.
Okay.
Yes,
Now,
I do.
now, similar thing happens for a positive strand RNA virus. If a positive strand RNA virus infects a cell, the cell will recognize that positive strand RNA virus as mRNA. So they can convert it from mRNA to protein. So they will just synthesize the protein. They will help it synthesize the protein so that it can package, the RNA inside that protein and it will make a complete virus. Remember that we are talking about a naked virus. It doesn't contain any protein. It's only the nucleic acid. So it needs to be packaged. So how it can be packaged and be infectious is when it enters and the host cell can make it synthesize the protein. So if it enters as a positive strand as RNA virus that is equivalent to mRNA, they will convert it from the mRNA to protein. When it forms a protein that is required to form, it will package that protein around the nucleic acid, the RNA, and they will form a complete virus, which is infectious. That is it. But if it's a case of a naked negative strand um, RNA virus, that negative strand is not mRNA, so they cannot take it to protein. So that means that they first need to take it to positive strand RNA. Now, to convert negative strand to positive strand, you need RNA dependent because you are already acting on one RNA. That's why we say RNA dependent, DNA polymerase to make another RNA. So you want to convert negative strand RNA to positive strand RNA, you need RNA dependent RNA polymerase. Now, if this virus was a complete virus that is having its capsid, its envelope together with it, part of those capsid will have this protein, this RNA dependent RNA polymerase, so that it can use it to do that itself. But what you are inoculating into that host is in naked form. So that means that it lacks all these enzymes. So it will want to rely on the host. Now, what we have said that the host have is DNA dependent RNA polymerase. They move DNA to mRNA, then they move mRNA to protein. They don't have RNA dependent RNA polymerase. So that means that this guy will not be able to be converted to positive strand RNA virus and it will not be able to get converted to protein. So there's no way it can package and form complete virus that will infect that host. That's why they are not infectious. Do we understand that?
So what would they now use? Where would they now get it from?
So that is what I'm saying. They cannot infect because they are naked. They can only
They cannot
infect
infect.
they can only infect if they are complete. You know that what we are looking at is naked form, not the
Okay.
original form, the naked one.
Okay.
Do you get it? So it's just like an experimental study. So you isolate the naked form of these viruses and you want to determine which of them will be infectious. So it means that the naked form of a negative strand, a negative strand RNA virus cannot infect because human cells, whole cells or eukaryotic cells do not contain RNA dependent RNA polymerase. Dr. Zulia, does eukaryotic cell convert RNA to RNA?
That makes sense to me
No, no,
now.
no, no.
Don't convert
It should
that.
be.
So I think
It
I
should
now
be.
get what you're
Yeah, I
saying
don't.
now.
Yeah. So the naked and the unnaked parts made it more clearer.
Yes. So we have to consider the fact that we are talking
So
about naked
a
nucleic acid.
naked double-stranded one, DNA one, is like a human cell. So the cell is going to help it. It will be able to infect the human cells because it's similar to the processes occurring in the human cell.
Fantastic.
So it will infect the cell.
Yes.
A positive sense RNA virus is even it's naked. So what will happen is the body is going to provide it with some machineries that will help it to translate the protein that will enable its virion to be produced and then to be able to infect the cell.
Why is the body acting on the positive strand? Why?
Because
it has enzyme that has made it already like mRNA.
No.
It's an mRNA now.
Is equivalent to mRNA. It doesn't contain any enzyme.
It's mRNA.
It's
Okay, it's already an
That's
mRNA.
what you want to do. Yes, it's mRNA.
It is equivalent to mRNA. That is it.
That is why I get what you wanted me to say.
So don't say it contains enzyme because all of them they are naked. They don't contain any enzyme.
Naked. Okay.
So they are naked. So the negative sense RNA viruses will not be able to infect a human cell, a eukaryotic cell, because they don't have both the protein, they don't have the protein form, and they are naked. So they have the protein form, and they are not similar to the normal human cellular transcription and translation.
mRNA.
You
need to convert it from negative to positive first.
Positive, yes.
Negative to positive.
Now, because I've been wondering what they were trying to say with this variants of negative strand. So some of them can convert it.
Look at the word.
Not the naked ones.
Not the naked
Yes.
So that is what these guys are trying to achieve. Whenever these naked guys enter, what they want to form is the virion. How will they form the virion? The virion is a term for a virus that contains the nucleic acid and the protein coat with the envelope. Do we get it? Like a complete virus.
Say it again. Sorry.
When you say virion is a complete form of the virus that contains the genome as well as the surrounding protein coat or the envelope. That is if it's the envelope though. You know that it's not all of them. But the basic thing that you must have is the capsid. You must have the capsid. So
which one is capsid now? Capsid is which one now? It's part of the coating, the protein coating.
You know, we talked about the capsid again. We said capsid can be helical or icosahedral.
Icosahedral.
Thank you very much. I now get it now.
I hope you guys understand this statement. This statement is very confusing if you did not take your time to read
the
it.
The statement at the top of the table, Abby. The naked nucleic acids of most DNA virus, except the pox and the HBV.
Yeah. So that's the exception. So those are the exception for the double-strand DNA virus. It is only pox and HPV that cannot work like that. So once they are naked, they cannot infect. That is it. So you must remember that exception. There's no reason why it's like that, but you know that's just what.
Because it's supposed to be able to infect since it's double-stranded DNA.
Yeah.
I mean, it's supposed to be able to use the body's own distance to do whatever.
They are the only ones. They are the only ones that do not follow that rule. So they cannot infect unless they are complete. So you have to know that. Then it's not only negative strand RNA virus that cannot infect when they are naked. The double strand RNA virus too. Because that one too is like this negative strand RNA virus. So virus like Rio, once it is naked too, they cannot use this mechanism. So that is that. So the principle for this.
I do not get that though. Are you trying to say that double-stranded what's it called? RNA virus also cannot infect Abby?
Yeah, since they are RNA. It's just like this negative strand single-stranded RNA. The double-strand RNA virus and the negative strand RNA virus, their template, they are the same. So both of them do.
Wait, sorry. I think the double-strand DNA. Did you just say DNA now?
No, RNA.
Okay. Okay, okay. The double strand RNA virus are the
Yes.
negative strand
See, that's why I don't want to be
single
saying SS.
strand.
That's why I want. See, the thing is, once you can say positive strand or negative strand, it's already single-stranded. That's when you can be saying it's. So once you say
Okay. Okay, so
negative
when I
strand,
just say strand, I mean single strand. So when I want to now say double strand, I'll just say double
double
Abby.
strand, exactly, exactly.
Okay. Okay. So now I wanted to get you very clearly. So you're saying that the negative sense RNA
Mhm.
and the negative double strand RNA, they are the same.
No, they are
Like
not.
in
You won't say the double.
like not like the same, like in terms of the whether they are going to need whether they're going to be infectious or not.
Yeah. So this is it. You see, this double strand RNA virus, before they can infect too, you need to convert them to mRNA. Now,
Okay.
if you want to convert them to mRNA, it's like you're also converting them to like a positive strand RNA you get, because that's
Okay.
equivalent to mRNA. Now, what enzyme do you need? You need RNA dependent RNA polymerase, because double strand RNA virus are RNA virus. If you want to convert them to mRNA, that's an mRNA. So you need RNA dependent RNA polymerase too to do that. Do you understand, Dr. Zubia? You need to
Okay.
take them to
Yes, I get.
mRNA. You need to take them to mRNA too.
Okay.
So if the host, and of course the eukaryotic cells don't contain RNA dependent RNA polymerase, so there's nothing they can do to it. They can't convert double strand RNA virus to protein directly. No, it has to get converted to mRNA first. Do you understand? So
Yes.
the reason why positive strand RNA viruses are enjoying is that the body recognizes positive strand RNA viruses as mRNA. So they just take it to protein
Okay.
straight. That is it.
Okay.
So please, you guys need to look at that statement again and make sure you understand it. So that there's no way they will twist the question, you'll be able to figure out what they are talking about. So what are the characteristics of DNA viruses? We said all of them have double-stranded DNA. So once you say DNA viruses, all of them have double-stranded genome, except the parvovirus that is single-stranded. And this parvovirus is the smallest. The largest is the pox. So don't forget, when we are talking about naked nucleic acid of DNA viruses that infect, we said all of them can infect except the pox and the HBV. So that
Mm.
pox is the largest. Parvo is the smallest. All the DNA viruses are double-stranded except parvo that is single-stranded. Now, what is the shape of the genome? Is it linear? Is it complex? Is it circular? So anyone that is not linear and is not circular, it's neither linear nor circular. You call that one complex. Example of that is the pox. So pox genome is complex. It's neither linear nor circular. So all of them are linear except three. All of them are linear except three. Now, I don't like the way they arrange this thing, because we should have talked about the types of the DNA viruses first before we can know um, which one is linear. So there are about 7 of them. 1, 2, 3, 4, 5, 6, 7. So these are the 7 DNA viruses. The herpes viruses, I know we are familiar with almost all of them. Herpes viruses, pox, partner, adeno, papillo, polyoma, parvo. So what I just do is that I try to, marry papillo and polyoma together. They are best of friends. They go hand in hand. They share so many things in common. Papilloma and polyoma. Remember those ones. Then these first three too, they have so many things in common. Herpes, the pox, and their partner. The herpes, the pox, and their partner. So what do we say about the pox? Anybody remembers?
Its naked form cannot infect.
Okay, that's
Yeah.
one. That's one. That's one.
Is the largest.
Is
Is the
Is the
largest.
largest. Is the largest.
mhm.
Yeah. So I think those are the two things that we said. And I said the okay. So let's forget about that, because I can see that they are talking about another thing now. So there's another place that we talked about the complexity. Sorry, I'm sorry. I'm sorry, guys. Okay. Uh, it's no longer here. I think they've removed that slide. Oh wow, they removed that slide. Okay. So we just assume that it's linear too. They removed that slide. Okay. So, so let's go back to that slide. The herpes, the pox, their partner. 3 things. They share so many things in common. What do they share in common? They are all enveloped. Epics, the pox, and a partner, they are the big guys, so they are enveloped. HHP, the epics, the pox, and their partner, they are enveloped. The other 4, they are non-enveloped. Adeno, the papilloma, the polyoma, and the parvo, they are not enveloped. They are not enveloped. It is only epics, pox, and a partner that is enveloped. You see, there's no way to, you can see that these things you guys need to learn them. It's not as if there's a, I'm sure you guys understand what I'm trying to say. You have to
Yeah.
Sure.
learn those facts. That is it. There's no way around it. You just have to
Yeah.
learn those facts. So epics, the pox, and the partner, they are enveloped virus. So now that is that about. The other ones, they are non-enveloped. The other ones, they are non-enveloped. Now, let's go to the DNA structure. So what happens to the DNA structure? What's the shape or what is the pattern of the strand? All of them are double-stranded. We've said that. It is only one that is single-stranded. Which one is that?
Um,
Parvo.
Pavo.
Parvo is the only one that is single-stranded. The other ones are double-stranded. Now, what happens to the shape? All of them are linear. It is only 3 that is circular. Now, what are these 3? You know, I've talked about papillo and polyoma together. So we just pair those ones like those are the 2 circular. Papilloma and polyoma, they are circular. Now, there's something about a partner. A partner, they are partially double-stranded and they are circular. So you must always remember this statement about a partner. They are partial double-stranded, they are circular, and they contain reverse transcriptase. That's the peculiarity of a partner. They are enveloped. Of course, we said the first 3 are enveloped. The epis, the pox, and the partner, they are enveloped. Now, a partner is partially double-stranded. It is partially double-stranded. It is now circular again. It now contains reverse transcriptase. I know it's a lot of information. See, that's my
It's really abnormal in greater way. Because it's partially DS, it's secular. And I agree what linear is the one that
yeah.
okay.
So you just marry the 3 that are circular. What are the 3? Polyoma, papilloma, a partner. Both of the 3, they are the circular ones. We've talked about the enveloped ones. A partner, epis, and
The
pox.
pox.
Now, the circular ones, papilloma, polyoma, and a partner. So the other ones, they are linear. The other ones, they are linear. That is all. That is all. So we've talked about, you know, that's just brief introduction about the DNA viruses. So they are all linear except the 3, which are circular. Papilloma, polyoma, and a partner. You can see circular. What about the RNA viruses? So now this RNA virus, to be honest, I don't think we really need to bother ourselves about the strand polarity. You hardly get a question talking about strand polarity for RNA virus, to be honest. What I think we need to major on with respect to the RNA viruses is segmentation. Those ones that are segmented. I think we need to know those ones. So AB, that's the first thing. I have already known that automatic viruses, they are segmented. Which virus do you guys remember that is segmented when we're talking about viral genetics? Which one?
Is it Coxsackie or Haemophilus?
No, influenza.
See, it's Haemophilus I'm calling influenza.
No, don't call it Haemophilus. They can be confusing. So it's just like saying what agent do you give vaccine against in someone that has COPD? They will put Haemophilus influenza there. They will put influenza.
They put it. I've seen it in questions. They put it. Actually.
Somebody will not get confused. You don't know. You just remember that influenza is there. Influenza is there. Which one of them? It is.
Jesus.
You are giving vaccine against the virus. Influenza virus. Then strep pneumo. That's the 2 things. Not Haemophilus influenza. It's someone that has COPD. Not Haemophilus influenza. Please.
Yeah.
For the segmentation, just remember, when we're talking about the concept of recombination and
recombination and reassortment.
So for reassortment, we said it occurs in segmental viruses. And the virus that we took note of was influenza virus. Influenza virus belongs to the family of the Otomyxo. The Otomyxo. Influenza is one of them. So you must always remember when you say segment, that should be the first one that should come to your mind. To me, I will not even tell you to pay attention to the number of segments. You don't need it. Just know that they are segmented. Otomyxo, that's number one because of influenza. Influenza is Otomyxo. I think it's the only one that is even there. Otomyxo, influenza. Then, then AB, arena, where you have your Lassa and the likes. Then Bunya virus, Bunya, arena, they go together. Arena and Bunya. Then you now remember the largest of those RNA virus, which is Rio virus. It's the only one that is double-stranded. Rio virus. So, the code is BOA. So if you can remember BOA, it's fine. B for the Bunya, O for the Auto, A for the arena, R for the Rio. So those are the segmented RNA viruses. Almost all of them are positive strand, except these ones. These are the negative strands. So the way I just try to remember them is that I start with my arena again. Arena, AB. I know that A will always follow B. They are together, everything. In terms of segmented, they are together. In terms of negative strand, they are together. So arena will follow the B. Arena, Bunya. Then I know that auto is negative strand too. So auto will follow para because they sound alike. Paramyxo, Automyxo. So they are together. So I remember my arena, my Bunya, my paramyxo, my Automyxo. Then, the FR. Philo and the Rhabdo and Philo. The other ones, they are positive strand. So your Rectro, your Toga, your Flavi, your Corona, Epis, Calici. Me, I feel that it's very difficult to remember the positive strand. So just remember the negative strand and convert the other ones to positive strand. So Arena and Bunya, Paramyxo and Automyxo, the Philo and the Rhabdo. So the way I always remember Rhabdo is rabies. Rabies, smooth muzzle, skeletal muzzle, paralysis of muzzle, rabies, Rhabdo. Then Philo, Philo virus. Yeah, Ebola, Philo. So that is that, guys. Philo, Rhabdo, Arena, Bunya, Paramyxo, Automyxo. They are the negative strand. The other ones, they are positive strand. So let's talk about another fact with respect to the viral envelopes. Now, one thing about the RNA virus is that
I thought you mentioned what's it called? Sorry. I thought you mentioned influenza as part of segmented at some point, but I did not see it as the things they are listing. Did I lose?
It's under
It's a
auto.
subclass.
It's under
It's an
auto.
example of auto.
Automyxo. All these things you are seeing, they are family names. You get?
Okay.
So under auto is the influenza. Do you get it?
Okay.
Yeah. So let's talk about the viral envelopes. Do you guys remember the 3 DNA virus that we said they are enveloped?
The polio, the pox, and the
Polio, okay.
Sorry, epis. Sorry, I don't know. Is epis, pox, and the epadna.
Yes, you've known it like that. Epics.
How did you know it, Dr. Zuriat? How have you known it? No.
Sorry, you said viruses which are what?
Which are
Envelope
enveloped.
DNA viruses.
Which are enveloped.
Which are enveloped.
Okay. Thanks.
Yeah.
So Epis, Epadna, and Pox. Epis, Epadna, and Pox have enveloped.
Look at the image.
Epis, Epadna, I don't want to see.
Oh, they
Epis,
are.
Epadna, Pox are
That's
enveloped.
how you can
Epis,
remember
Epadna,
But what virus is
Pox are
Hepadna? I've
enveloped.
never.
That's
thought
hepatitis B.
Pardon?
Visuals will help you.
Hepatitis B.
Because but I thought, isn't it just the. It's fine. I've answered my question. Thank you.
Okay. Epis, Epadna, and Pox. Epis, Epadna, Pox are enveloped DNA. Thank you.
So, now, one thing I just want to mention about the viral envelope is that almost all the RNA viruses, they are enveloped except like 4. And the code I use for that one is PEG. PEG. So PEG is the code that I use. So let's go to those guys. You can
For
see that
which one?
for the RNA viruses that are non-enveloped. So
Non-enveloped RNA viruses. Okay.
almost all RNA viruses are enveloped except 4. Do you get it? All the RNA
Uh-huh.
viruses, they are enveloped except 4. What are these 4? The code is PEG. Now, this PEG is a code for the viruses that are under PICONA, but I'm also using it for the viruses that are non-enveloped. It also works. You just have to remove the E. Do you guys get that? Hello?
Maybe
Yeah,
when you
we're with
land.
you.
So don't worry. This is the part that you need to memorize. There's no way you can go about it. You just need to memorize it. Hmm?
So you
So
said P, skip E, then R, then C, then H, right?
yeah, page. You guys just need to remove the E. So what is the P? The P is the PICONA. What is the R? Real virus. What is the C? Calisi. What is the H? Epi. Not epizo. Epe or something. I don't know. Epi. Just don't put it as epis. You know that epis is not a RNA virus. Hope you guys remember that epis is what? DNA
Yes,
virus.
herpes is a DNA, enveloped DNA virus.
But there's epe or epi. No S. That is sounding like epis, but it's not epis.
But they cannot look for another name.
No,
Why
there's no
must
R, safe, Dr. Babali. There's
Yeah,
no
there's no
R.
R. There's no R too. Thank you, Dr.
No
Toby.
R, no S.
So you said these ones are which viruses?
Non-enveloped RNA virus.
So all
Dr.
the other
Babali,
RNA viruses are enveloped.
Dr. Babali, they
Yes,
can be
Mommy.
preached now. Oh
You
no,
can
the
what?
I is missing.
Yeah,
PIRCH.
it will still be the same thing.
Uh-huh.
So just use this patch. This patch will help you because you'll be able to remember what is under
Yeah.
the corner too.
And then considering that they're even both RNA viruses, yeah,
So
that makes sense. Yeah.
so let's go back. Let's go back to you can see that the stuff is a little bit clumsy.
See, it actually requires us saying it again and again and again. But at least it's now we are not having to like cram so much because we now understand some of the things you are saying. Do you get?
Yeah. So we've talked
It's
about
easier to cram now.
we have talked about the envelope DNA virus, the EPIs, the partner, and the POX. We've talked about the enveloped RNA virus. Those are the other ones, except 4, which is the PEG, the PICONA. We are removing the E. We are going to the R, which is real, the C, the Calisi, the H, the what? Epi, HEPE. That's it. So now what is about this viral envelope? Almost all of them get to synthesize their viral envelope by using the plasma membrane of the cells that they infect. They get the viral envelope from the plasma membrane of the cell they infect. As they exit those cells, they will take along a portion of the plasma membrane so that they can form their own viral envelope and be covered. The exception to that is the herpes viruses. They don't get their own envelope from the plasma membrane. They get it from the nuclear membrane. Are we taking note of all these
Yeah.
exceptions? Yeah.
After a lot of exceptions, no go bust with exceptions.
Yeah. So like we can always take it one by one. The DNA virus, what did we say about them? We said that almost all of them are what? Double-stranded.
Double stranded,
Double-stranded, yes.
It is only
except
one
parvovirus.
that is
Which is
single-stranded,
the
which is parvo. Now the next thing is to look at. We've talked about
parvo, the smallest, yes.
yeah. So when you
The
talk about the
smallest.
strand of DNA virus, the next thing is to talk about the shape of the DNA virus. Is it circular or linear? We said that 3 are circular. The other ones are linear for DNA virus. What are the 3 circular?
The circular ones are
The
the
circular.
P, papillo,
PHH.
polio,
Okay, papillo, polio,
and
herpes.
the
Why are we saying polio like
Epadna.
this? Where we see polio?
Sorry.
Eh? polio is somewhere else. So we
I
said
thought you said polio was circular. You said anywhere papilloma, we should put polio too.
no, I did not say polio. I said polioma.
Polio.
Polioma. Oh, sorry.
I
Hey,
beg.
my
Polio is
baby.
a
Polio
common.
náà ni mo mean.
For
Polioma, like
polio,
POLY
actually,
náà ni mo
polioma.
mean.
I'm just scared because polio virus also
Because
exists.
this okay,
No,
polioma.
the bàbá like polioma ni.
Polioma, papilloma, and a partner. That is settled. We talked about enveloped ones. We said only 3 are enveloped. So what are the 3 enveloped ones?
Herpes, partner,
Herpes,
and
partner.
And what?
and adeno.
Ah,
Sorry. I'm not even.
you see, that was what I'm saying about the visuals. You need to
And
look at
pox.
it. Look at it. The first 3. Those are the
Herpes,
enveloped.
partner, and pox.
And
What?
pox. Just assume that these ones are the biggest. Just assume that these ones are the chairmen. How many infection of parvo do you see? How many infection of polioma do you hear? How many infection of papilloma is quite popular, but it's down. I don't know. But herpes has so many organisms under it. Pox, biggest. A partner, hepatitis hepatitis B is the chairman. So you can always remember all those ones. Herpes, a partner, pox. All these other ones, they are down. So once you can look at the arrangement, you'll be able to palm, I already know when we talk about circular, we remember the P's. Circular, the P's, polioma, papilloma, and what? And our partner, circular DNA. And don't forget, a partner is partially double-stranded. Partially double-stranded DNA. You guys are learning it small. With time, you master and you just be flowing with the stuff. So it's just that you guys don't have the time. Is the D-Day is next month. So, but I know that before that time, all these ones will have been spinal. So yes. So that is that. And you guys, we talked about the viruses, the RNA ones. We said almost all the RNA, they are enveloped, except how many?
4.
4. Thank you. So what are the 4 that are not enveloped?
You said patch.
Patch.
The
Okay.
Picona, the
Picona.
Rio, the Calici, and the EP.
The EP. Yes. Now, we said majority of them are positive strand except some. I know that we don't have a definite code for that one, but we said you must remember automyxo first. Automyxo first is for segmented. You remember AB. So AB, arena, then you take your bunya with it. Then you now remember your myxos, your automyxo, your paramyxo, then your FR, your philo, and your rhabdo. Once you guys can even remember like 4 or 5 of them, you are okay. They hardly said question on philo or rhabdo. So, once you're able to palm your myxo and your arena and bunya, I feel you're okay. So that's that. All right. So let's start going to the pathologies. Yeah. So these are the DNA viruses again. We are looking at them again. The herpes virus, we are going to talk about them one by one later. So I don't think this is so we are going to talk about them one by one. They're about 7 or 8. Yeah, 8. They are 8 actually. So that's that about the herpes. They are one of them. The pox is the next one. So quick, what is the clinical relevance of the pox virus? What does it cause? What's the pathologic relevance? Pox virus can cause 3 infections. Pox virus can cause 3 infections. Smallpox, cowpox, and molluscum contagiosum.
I thought you said chickenpox.
No. Chickenpox is what? Is under the herpes.
Varicella.
That is varicella. So smallpox has been eradicated, but it is believed that there are still some strains of smallpox in some labs in the US and maybe in some other Asian countries, but it has been eradicated. So we don't really need to focus on smallpox again. But another thing that we just need to pay attention to about smallpox is that it's the vaccine is a live attenuated vaccine. So the vaccine of smallpox is a live attenuated vaccine. And you guys know what live attenuated vaccine means. What does it mean when we say the vaccine is live attenuated? Anybody? Guys, we just did immunology. This thing should be. I should be begging you guys to.
There'll be
I
a
mean,
robust response. Okay?
they just probably removed
You
some
guys are not
parts.
saying it. You guys are not saying it
That
well.
means a portion of the virus is removed and then used to produce the vaccine.
Okay. So the vaccine can stimulate immune response, and it can grow. It has the potential to retain its pathogenicity, although its pathogenicity is it's kind of reduced, is attenuated, but it still retains the ability to grow in an inoculated host. And if you are not careful, if that host is immunosuppressed, you have introduced that organism to the person, and the organism will just be thriving, be proliferating uncontrolled, and will be causing infection. That is it. So you don't give a live attenuated vaccine in someone that is having CD4 count less than what? Anybody?
200.
200. Fantastic. 200. Or someone that is pregnant, you don't give it because of the immunosuppression. So there's a lot of them, and I know that we know them. Smallpox is one of them. Cowpox is also one of those infections that you can get from pox virus. It is very common in people that milk cow. So people that milk cow at their udder, so they touch the udder. Those cow can get infected with the pox virus that cause cowpox, and they can develop some blisters on their hands. So we call it milkmaid blisters, cowpox. You just see some blisters on the hand. They cannot have this one. It's not a common disease. Now, the last one is molluscum contagiosum. So this is the one they can ask us. So they can ask us to make diagnosis of this guy, and the next thing is what class, what is the family of the organism that is causing this infection. So the pox, and that is the largest DNA virus. So how would it appear? This statement is classic. Once we hear flesh-colored purple with central umbilication, that is molluscum contagiosum until otherwise proven. Flesh-colored purple with central umbilication. So, they affect the skin. So that's where you see the lesion, and the viruses are going to form some inclusion bodies within the keratinocyte of the skin that we call molluscum body. So this is it. So you just see something like a dimple invagination of the epidermis into the dermis. So you guys can see this. This is what it looks like. Can you guys see this? But it's unlikely for them to show us an histology. So most of the time they will show us the gross lesion. They will describe the gross lesion with the central umbilication, or they show us a picture of that. So that's that about molluscum contagiosum. Then hepadna. Hepadna, the only virus that is contained within the family is hepatitis B, which can cause both acute or chronic hepatitis. It is not a retrovirus, but it contains reverse transcriptase, because it is not only a retrovirus that contains reverse transcriptase. Do you guys want to ask me the relevance of this reverse transcriptase? Because when you say reverse transcriptase, you are converting RNA to what? To DNA. You guys, that's like transcription is converting DNA to RNA. So when you are now converting it backwards, you are converting DNA to RNA. RNA to DNA rather. That's like a backward transcription. So that's reverse transcription, and you need a reverse transcriptase to do that. Why does this virus need this thing? It needs that reverse transcriptase to be able to duplicate its copies so many times within the host. Once somebody gets infected with hepatitis B, they travel to the hepatocyte, and which other organism have we talked about in this microbiology that we said once you inoculate that organism into the host, the first place they go to is the liver? Anybody? They go to the liver.
Plasmodium.
Entamoeba.
Entamoeba ni mo fẹ́ sọ. Àbí?
Ṣé entamoeba la sọ? Kì í ṣe entamoeba. Ẹnìkan ti
Plasmodium.
sọ plasmodium.
Plasmodium.
Plasmodium. The entamoeba one is a complication. That's an invasive form of entamoeba. Once you see liver
Plasmodium around the person.
okay, so it's fine. So plasmodium. Yeah. So acute and chronic hepatitis from hepatitis B. So we're talking about the reverse transmitted. Just summary. So once they get into the host, they get to the liver cells, they get to the nucleus of the liver cells, the partial double-stranded DNA will be converted to full double-stranded DNA. So once it gets converted to full double-stranded DNA, they are going to convert it to mRNA, and they are going to convert that mRNA to protein. So that means that they are already synthesizing the protein that the virus will use to make more copies. Now, that double-stranded DNA that is getting converted to mRNA, they will now convert that mRNA backwards to DNA again by using their reverse transcriptase, so that they can have many DNA available to package inside those proteins that they are synthesizing initially, so that they can form more copies of the hepatitis B. Because you guys remember that hepatitis B virus is a DNA virus. Does it make sense to you guys? Does it make sense to us?
To me, not fully yet though. Like, I'm struggling to put it together.
Okay, I know where the problem lies. Now, you must always understand that a viral contains the genome and the protein code. Do you understand, Dr. Julia?
Okay.
The protein can be so many things. The code, the enzyme that is going to use, proteins. You get that?
Okay. Yeah.
Now,
Mm-hmm.
when that virus infects the host is going to convert it to DNA virus. It's partial. They are going to convert it to full. Everything will not be everything
Okay.
will not be full. Now, that double-stranded DNA virus is now going to get converted to mRNA by the host. You know that is the host that has DNA-dependent RNA polymerase. You get?
Yes.
So they will take it to mRNA. So when they get to mRNA, the host will convert it to protein, Abi. But the protein is not for the host too, because the genome they are transcribing or they are translating is the genome of the virus. So it is viral proteins that they are producing. Do you understand? Now, some of those mRNA will not get converted to protein. So the virus is now going to use its own reverse transcriptase, because the host doesn't have reverse transcriptase. The virus will use its own reverse transcriptase to now convert some of its mRNA back to the double-stranded or the partial double-stranded DNA.
Partial double-stranded DNA, okay.
Yeah, so that they can now package it into the protein that they are initially synthesized, so that they can form new variants. Do you get it?
Okay.
They can form new variants.
So that's like a replication something, right?
That's the way they replicate themselves. You get it?
Okay.
That is it. So hepatitis B can cause acute and chronic hepatitis. That is what it causes. That's all it causes. Although there are so many things that hepatitis B can cause, but its major pathology is the liver, but it has so many associations. You guys know hepatitis B can be present in membranous nephropathy. We know that, right?
Yes.
It causes a lot of things. It's hepatitis B, this guy, a lot of things. Polyarthritis nodosa. I hope you guys agree with me. If you see hepatitis, if you see someone that has polyarthritis nodosa and they are telling you want to rule out the virus, which virus are we talking about?
HBV.
HBV. In 30% of people, they will have HBV. So you must learn the association of hepatitis B. Adenovirus is the next one. It's not enveloped. It's double-stranded. It's linear. It can cause so many things. That's one thing about adeno. It can affect the heart, can affect the lungs, can affect the eye, can affect the throat, can affect the GI. So let's start again. The GI, the heart, the lungs, the throat, and the eyes, even the bladder. Now let me mention one thing about adeno. Once they mention adeno, one thing that should come to your mind, although it's not high yield, but just to remember everything, completely, is pink eye. You see, the most common viral cause of pink eye, conjunctivitis, is adeno. You can never be wrong. It is adeno. Adeno is a serious virus that is implicated in causing pink eye conjunctivitis. The next thing is to pick the two organs that are similar together, the heart and the lungs. Pneumonia and myocarditis. Pneumonia, myocarditis. Pneumonia, myocarditis. So because of the fact that you can get adenovirus apart from inhalation causing pneumonia and myocarditis, you can also get it fecally. It can cause gastroenteritis. And of course, it can also find its way. So the inhalation route can cause the febrile pharyngitis, which is sore throat. It can cause the pneumonia. It can cause the myocarditis. The what's it called? The fecal oral can explain the gastroenteritis that it causes. Then when it gets to the blood too, it can disseminate and cause acute hemorrhagic cystitis, particularly in people that are young. So they will just have passage of dark color urine, with no pain. There's no dysuria. We just have passage of dark color urine that is painless. Hemorrhagic cystitis. Adenovirus is implicated in that. Then, of course, the pink eye that I mentioned earlier. So they are very notorious for causing conjunctivitis. So once you remember the pink eye, conjunctivitis, remember the inhalation route. So that can explain the myocarditis, the pneumonia, the strep throat that they cause. I said strep throat, the pharyngitis that they cause, the sore throat. Then the GI, fecal-oral gastroenteritis, and they can also affect the bladder and cause hemorrhagic cystitis. If you cannot remember all, I know that we will still be able to remember the majority, right? I've been now Dr. Toby for adenovirus.
Yeah, conjunctivitis, acute hemorrhagic cystitis, bladder, eyes. It's just
GIT.
Heart and lung.
Heart and lung. Heart and lung. Heart and lung.
No, she has said heart and lung.
I said that.
Count
Okay.
eyes.
Okay, eyes, heart and lung. Then the bladder.
The bladder. So acute hemorrhagic cystitis. You guys can see this inflamed pharynx. So that is a febrile pharyngitis, sore throat. So
That's so true.
Polyoma. I said polyoma. Papilloma. Papilloma is just HPV, human papilloma virus. It's usually sexually transmitted. So it causes wart and cancer. So it can cause both cutaneous wart and the what's it called, the anal or the genital wart that it causes. So let's just say wart generally. And the strains that are implicated in causing the wart include the serotype 6 and 11. Those are the two major ones. And you guys remember that it can cause the laryngeal papillomatosis that we talked about the other time, which is like benign tumor of the vocal cords. So 1, 2, 6, and 11, but commonly 6 and 11. 1, 2, 6, and 11, but commonly 6 and 11 for the wart. Now, these guys are implicated in causing squamous cell carcinoma of almost anything, from the head and neck to the external genitalia. So once you see somebody having oropharyngeal carcinoma, you are thinking of papilloma. See somebody having cervical cancer. Cervical cancer is actually the most prevalent cancer that it causes. Like the commonest cancer that papilloma is implicated in causing is cervical. Like everybody knows that one is basic stuff. Papilloma causing cervical cancer. It can cause penile cancer, it can cause anal cancer, it can cause oropharyngeal cancer. So don't forget that head and neck, oropharyngeal, the cervix, cervical, the anal, the penis. So if it's not cervix for the female, it will be the penis for the guy. And of course, the anus is common to both sexes. So the penis, penile cancer, squamous cell type, the cervix, cervical squamous cell carcinoma, the anal region, cervical squamous cell carcinoma of the anus, oropharyngeal cancer. And the serotype that are involved in causing the malignancy, serotype 16 and 18. Polyoma virus. Two organisms that I want you guys to remember for polyoma. Please don't forget this stuff. Many people don't know this stuff. And that is what I want you guys to pay attention to, because this is what is going to be separating us from the basic people. Knowing polyoma virus. You guys can think I'm joking, but I'm actually being serious. Many people don't know polyoma. They just, what is polyoma? Polyoma is IU. They can ask it. It's one of the jokers. What are the two organisms that you want to remember for polyoma virus? JC and BK. So these viruses are actually named after the people that they first discovered the virus in. So the people that got infected first with this virus and they were discovered are those. So the initials of the name are the JC and the BK. So I think JC is James Cunningham. I can't remember the BK again. So you guys remember JC from our neuro. We talked about progressive multifocal leukoencephalopathy.
Causes PML.
Yeah. So what do you guys remember about PML? Just a quick.
I know that it's fatal.
Okay.
And it's like very fast, like rapidly progressive.
Fantastic.
Leuko something. There are areas of white this thing on a CT scan, and it's common in immunocompromised patients.
Okay, yeah. So what I just want you to also mention is the site of the brain that is predominantly affected. Which site?
Is it the temporal lobe?
No, it's not temporal. See, once you guys see temporal lobe, and you are thinking of an infection, quick one. It will,
HSV.
you are doing fantastic. HSV, that's it. HSV. It will always be HSV. HSV causing temporal lobe encephalitis. No other organism is common in causing temporal lobe encephalitis than HSV type 1. Don't forget, it's not even under HSV, type 1. That is it. That is it. So, your PML from polyoma virus, particularly JC type, affects the occipital lobe and the parietal lobe. Don't forget, you'll be seeing the hypo intensity, maybe MRI or something, affecting the parietal lobe and the occipital lobe. So they can have visual problems. So once they tell you that somebody is immunocompromised, is having visual problem, is having personality changes, behavioral thing, you know that that's likely to be, activation of the latent form of, because this guy is always, present. It's just latent. So whenever there's a background immunosuppression from any cause, maybe HIV, maybe someone that's using steroid immunosuppressant for transplant and all those things, or someone that has used with medication. Do you guys remember any medication for JC? That medication is using
Natalizumab.
natalizumab. So natalizumab immunosuppressed stage from anything HIV, they can have JC virus, which will present with problems affecting the occipital lobe, causing visual problems, and the parietal lobe. Those are the two areas. The next one is the BK virus. This one is very, very common in people that have just received a renal transplant. So you just paint the history, someone that just received a renal transplant. After some time, you start noticing the person having passage of dark color urine. The person is having an increase in the serum creatinine. Please, this is not nephrotic. This is not nephritic. This is BK virus infection. BK virus infections. It affects, newly transplanted kidney in individuals, and they can present with hematuria as well as a rise in the urea and creatinine level. Don't forget that BK kidneys, transplant patient, JC immunosuppressed, natalizumab, parietal lobe, occipital lobe. That's a polyoma for you. They are DNA viruses. Parvo is the last one. Parvo causes the B19 serotype of parvo is what we are interested in. That is the one that is responsible for most of the infection. These guys can infect so many population. It can infect pregnant people and cause some of those touches infection. It can infect adults that are even immunocompetent and cause rheumatoid arthritis-like symptoms. And it can affect children and cause slap cheek. It can now infect people that are having sickle cell and cause a plastic crisis. So when we say a plastic crisis, from our knowledge of immunology, it means that all the 3 cell lines are affected, right?
No,
Okay.
aplastic anemia.
So that is a plastic anemia. So in a plastic crisis, it is only the red cell lineage that is affected. So one thing about this virus is that it has affinity for affecting the red cell precursor that still contains the nucleus, particularly the reticulocytes. So it will go in because it inhibits the S phase of division. So it enters, arrest those guys at the S phase so that the reticulocyte cannot progress. You guys know that the reticulocytes still contain nucleus, so they can have all those mitotic stuff, S phase and the likes. So to arrest them at the S phase, they can no longer divide into the matured form. So that's what happens, and that infection is very bad for someone that has sickle cell anemia, because in people with the sickle cell disease, the red cell turnover is very, very high. So they are losing their red blood cells because they are immunizing actively. So if you are now coming and you are now infecting the red cell precursors in the bone marrow, how will these guys replenish all those red blood cells that they are even immunizing themselves? So that means they can suffer anemia easily, and that is what we call the aplastic crisis. So this aplastic crisis will not typically occur in an elderly person, because if an elderly person gets infected with a parvo, it will affect some of the reticulocytes. They will not grow, but they can, rapidly proliferate more and produce more. But in people that have sickle cell, they are embolizing the ones that they have in circulation already. We are now going to the bone marrow and be destroying the precursor again. There's nothing left. So that is why aplastic crisis is very common in people that have sickle cell. And don't forget, it's only the red cell lineage that is affected in the aplastic crisis. So what is the infection that it causes in children? So you notice some constitutional symptoms initially like fever, headache, then subsequently they develop the rash. So the rash typically occurs in the cheek. So that's why they call it the slap cheek, as if you slap a baby. You don't see slap cheek presentation, slap cheek rash in an adult. You don't, or adolescent. You don't see it. You only see slap cheek rash in children affected by parvovirus. And we call that erythema infectiosum, or the fifth disease. Slap cheek rash in children is called, so these guys can easily spread the virus to other colleagues within the school. So it's very, very infectious. So they can easily, spread it, and everybody will just start developing the slap cheek appearance. So we've talked about that it infects the red blood cell precursor and cause the aplastic crisis. Now, if a pregnant woman also gets infected, it can the pregnant woman can transmit the virus across the placenta to the fetus. And what it causes in the fetus is what we call hydrops fetalis. So this is like when you have edema, generalized edema of a fetus, which will eventually result in death. Why? Because it's going to infect the red blood cell precursor and the endothelial cell. When it damages the red blood cell precursor, there's going to be anemia. So when there's anemia, there is what kind of heart failure does anemia cause? Anybody?
Cardiogenic.
No.
Anemia.
Anemia.
Hypovolemic.
No.
Distributive.
No.
Okay. No, serious is shock. It's septic shock.
The typical heart failure that is common, that stuff is also in beriberi. It's also in thyrotoxicosis.
High output.
High output.
Why is anemia causing high output?
Well,
It's
it's part of it.
overworking. It's overworking.
There was something else that I even thought I was shocked that you two are here.
Yeah, anemia is there. In fact, anemia is one of the pioneer. Anemia,
Yeah, anemia.
thyrotoxicosis, wet beriberi, arteriovenous fistulas, all those things. Why? Because in anemia there's hypoxia. So there is little delivery of oxygen to the tissues. The heart is going to sense that one as, is it that we are not pumping enough blood to those tissues? They'll start overworking. When they overwork, they try to pump beyond their normal cardiac output. And at the end of the day, the amount of blood that is going to be returning to the heart as a preload is going to be more than what the heart can handle. Eventually, it will fail. And that is the cause of the high cardiac output failure in anemia. Very, very important. So, so that edema that is not happening when the heart fails, coupled with the fact that this parvovirus infect the endothelial cells, damaging them, create a pathway for fluid extravasation into the tissues. There's going to be edema. So at the end of the day, the fetus is going to present as, just generalized edemato state. And that's what we call the hydrops fetalis, which will eventually result in the death of the fetus. So once you see hydrops fetalis from hydrops means accumulation of water in a fetus from an infection. That is parvovirus they are talking about. And it can cause pure red blood cell aplasia. So pure red blood cell aplasia just means that you have destruction of all the precursors of the red blood cells. That's what it means. Aplasia of red blood cell. So aside parvovirus, there are so many things that can cause red blood cell aplasia. Someone that is using this guy, erythropoietin, they can cause red blood cell aplasia. Someone that is having this guy, thymoma. So part of the association of thymoma is red blood cell aplasia. So just notice that the reticulocyte count, red blood cell total count, they are decreased. Red blood cell aplasia. Your white blood cell count is normal. Your platelet is normal. So that is red blood cell aplasia for you. So you want to rule out thymoma, that kind of person too. Yeah. So in adults that get infected with parvo, what would they have? They will not have the slap cheek rash. They will have a rash that is within the trunk and the extremity. And they will have some rheumatoid arthritis-like joint symptoms. What are we talking about? You are going to have stiffness of the joints. So that means that if we see early morning stiffness, we should not quickly go and jump to rheumatoid arthritis. We want to calm down and look at, okay, is this a possibility of a parvovirus infection? So there's going to be stiffness of the, the joint, particularly the hand, the small joints of the hand. Then it can also affect the knee as well as the wrist. So the wrist, the smaller of the hand and the wrist. So of course, because we are saying rheumatoid arthritis like, So we don't expect this ones to be affecting which joint of the hand like that. Anybody? Since we are saying rheumatoid arthritis, I want to know if you guys can remember your
Shouldn't affect the carpal metacarpal, and it shouldn't affect
the first carpal metacarpal.
the
Okay.
first carpal,
Mm-hmm.
and it shouldn't affect the
There's one that is
I
very
say
common. There's one that is very
the
The
common.
distal.
The
distal
distal
phalanx.
interphalangeal joint. The distal interphalangeal joint. Yeah, that is it. Once you see it in the question that there's affectation of the distal, my sister, my brother, that stuff is not rheumatoid arthritis. Delete it immediately. It is not. It is not. It is not. So don't forget. So someone that is having parvo can have parvovirus arthritis. Stiffness, pain, swelling and all those things involving the small joint of the hand, sparing the distal, as well as maybe the large joint like the knee and the wrist. And of course, they will have the rash with them, particularly in the trunk. So don't forget that. Yeah. So let's go to the herpes. The herpes virus, they are envelope virus. We've said that they are double-stranded, they are linear, they are not circular, they are linear. The three circular are the polyoma, the papilloma, and their partner, not the herpes. So we have about 8 of them. And okay, so let's start taking them one by one. Herpes simplex virus 1. What does it cause? It causes so many things. How is it transmitted? Respiratory secretion and saliva. So it has similar presentation or similar route of transmission like someone that has Epstein-Barr. So people that are kissing, they can exchange saliva. People that practice oral sex can exchange saliva. Sneeze, respiratory secretion can get into somebody. They can transmit herpes simplex virus. So herpes simplex virus 1, I just want you guys to pay attention to the fact that it is predominantly causing oral lesions, oral pathologies. So the first is the gingival stomatitis. So there's inflammation of the gums, and there's some vesicles formed within the anterior portion of the oropharynx. So oropharynx are the back of the mouth, the anterior portion. Gingival stomatitis. It's very painful. One thing about these herpes guys is that their own typical lesion is in form of vesicles. So they'll be forming fluid-filled cavities, that are very painful. Very painful vesicles. Painful. Once you see vesicle, you want to calm down and rule out herpes. You must always calm down to rule out herpes when you see vesicle in a question. Herpes will most likely be the correct answer. So if it's not vesicle, if it's not herpes, it can be varicella. But most of the time, if you are finding it in the oral area or the genital area, this is herpes they are talking about. So the gingival stomatitis, of course, we are talking about oral lesion. Inflammation of the gingiva, formation of vesicles that are very tender and painful at the anterior aspect of the oropharynx. Gingival stomatitis. The next one is keratoconjunctivitis. So this guy is also one of the causes of inflammation of the conjunctiva as well as the cornea. So they can cause keratoconjunctivitis. We've said one major cause of conjunctivitis is what? Anybody? Which virus did we mention?
I don't know.
I don't know.
Adenovirus. Yeah. So let's leave the. Okay, so let me just quickly talk about the herpes labialis. So these herpes labialis are just you having the vesicles, these painful vesicles within the mammalian border. So you guys know that there's a border between the lips that what separates the upper lip from the chin. You guys remember that thin line?
Probably so.
So at that region, you have the vesicles from there. So that's what we call herpes labialis. Now, this guy is very common following reactivation. So it doesn't occur as a primary lesion. If somebody is having a primary lesion for herpes simplex virus 1, it's going to come in front of the gingival stomatitis. If there's a subsequent reactivation, it's going to come as a herpes labialis. Painful coat sores within the lips. They can develop hepatic whitlow. So they can have whitlow. We don't have the image again. Yeah. So this is the keratoconjunctivitis. Yeah. You can see here. So it's just looking. They've stained it with all this dye. That is why it's looking like this. So this is the herpes labialis in people that have reactivation of the herpes virus. So hepatic whitlow is also caused by the herpes simplex 1. How? It's very common in people that work in the hospitals, like healthcare workers, particularly dentists. So when they are, working, they are doing some dental procedures in the mouth, they can easily, inoculate into the organism into their hands, and they can develop infection of the distal part of or the proximal part of the finger. So it's very painful. I thought we have one image here before they have removed it. So a petit whiplow occurs when there is manipulation of the mouth. So when you are doing some procedures, the epitic whiplow in people that are working on some oral procedures. So if you are performing oral procedures, you can inoculate the organism from oral manipulation into the hands, and the person can develop the epitic whiplow. Another thing to talk about is that herpes simplex, particularly in disseminated form, can affect the esophagus as well as the brain. So they can develop temporal lobe encephalitis as well as esophagitis. So the classic presentation of the esophagitis, you are going to having those vesicles within the esophagus, and it's going to form punched out ulcers. Abby, you guys remember that punched out ulcers, right? So what is the nature of the ulcer for CMV in the esophagus? Hello?
We can hear.
Hello?
We can hear you.
Yeah, so I said what's the
We hear you.
yeah, so I said it can cause temporal lobe encephalitis and esophagitis. So I said what's the nature of the esophagitis in CMV?
Linear
Linear.
ulcerations.
So for someone that has the HSV, they are going to have the vesicles within the esophagus, and it's going to appear
Punched out.
punched out ulcer. Yeah. So they can cause erythema multiforme. Which other organism can cause erythema multiforme? There's a lot of them. There are a lot of them, but we've talked about one. Recently talked about erythema multiforme. We mentioned one organism. That organism can cause Steven Johnson too. It can cause TNS. Steven Johnson rather. Steven Johnson. We said it, that organism. Do we remember? Erythema multiforme.
Hello?
So,
Can you
do we,
guys hear me?
do we remember the organism that can cause Steven Johnson? Dr. Oluwatobi, we can hear you.
Okay.
Do you remember the organism that can cause erythema multiforme? These are questions I'm asking you.
Not strep bile genes.
Erythema multiforme. Triple gene. No, we did not mention
Mycoplasma.
mycoplasma pneumonia. Mycoplasma pneumonia. So we said it can cause SJS2. It can cause erythema. It can cause pneumonia, atypical pneumonia. So it's responsible for growing partial herpes genital. Yeah. So these guys can become latent. Particularly herpes simplex 1, herpes simplex 2, varicella zoster virus, as well as CMV. Those 4 guys can stay latent. Yeah. So what's the site that this type 1 prefer? It stays latent within the trigeminal ganglia. So because of the fact that it's in the head, so it affects the mouth. So we expect it to stay in one of the cranial ganglia. So it preferentially stays within the trigeminal ganglia. So that's where it becomes latent. So when there is some form of immunosuppression, it can come out and cause secondary infection. And we said the secondary infection for herpes simplex type 1 is what? If it comes out again, what does it cause?
And the vermilion border.
Ophthalmic cause.
No. When it becomes reactivated, it will cause the herpes labialis.
Something on the very long border.
Herpes labialis. Herpes labialis.
Cold sores.
Yeah. Can you guys see my screen? All these things I'm saying are on the screen. Oh. Hello? Hello?
We can see it though.
Now, when you guys are now saying vermilion border, I'm not saying all those things on my head though. Herpes labialis is what I said. You grow on the vermilion border and it is on the screen. Please, as I'm saying, please be looking at the screen so that you guys can follow what I'm saying. So, it is the most common cause of sporadic encephalitis, and we said the encephalitis typically affect the temporal lobe. So how will they present? Because of the fact that it's an encephalitis, it's already affected the parenchyma of the brain. So they can have altered mental status, they can have seizures, they can have aphasia. So that aphasia is one of the pointers to the fact that the area that is affected is temporal lobe. So what type of aphasia would this person have, most likely, if it's temporal lobe encephalitis?
Wernicke.
Yeah, so the person will have a Wernicke aphasia. That's very good, Dr. Toby. So, and you guys should not forget Clever-Bushey syndrome. So it's also shared with this temporal lobe encephalitis. Do you guys remember Clever-Bushey syndrome?
Hyperphagia, hyperorality.
Hypersexuality.
Exactly. So due to what area is affected? What area is typically affected in someone that has this hyperphagia or hyperorality? What area of the brain?
Peripheral
Temporal
amygdala.
lobe.
No, like you have to be precise. What area in the brain? Not temporal lobes. What part of the temporal lobe now? Okay, so
Bilateral data.
the bilateral.
Yeah, the amygdala.
Yeah, the amygdala. So the amygdala.
Amygdala.
Yes. So the amygdala of the limbic system. That's what is affected. Okay. So the herpes simplex virus 2. This one affects the genital tract. So you will not typically get it through respiratory secretion or saliva. So it's by sexual contact or by delivery, perinatal delivery. So that is the fact that it can be acquired perinatally explains why they can develop neonatal herpes. So we can have neonatal herpes, and the sexual contact one can, cause the herpes genitally. So you find the vesicles within the genital region. So you find those vesicles that are there. That ulcer is described as being painful, and they can be shared inguinal lymphadenopathy that is tender to. You see the ulcers, they are deep, and they are in vesicle forms too. The ones that are not ulcerated, they are in vesicle forms. Yeah, so don't forget that. Don't forget about herpes simplex virus 2. And another thing worthy of note about this type 2 is that it can also cause meningitis. So the type 1 causes encephalitis that predominantly affect the temporal lobe, while the type 2 causes meningitis. So meningitis is common for type 2 rather than type 1. So when somebody has viral meningitis and you are thinking of virus, one of the viruses that can be implicated is the herpes simplex virus 2. It stays dormant within the sacral ganglia. Of course, this one is in the genital area. So the sacrum is very close to the genital. So it stays, latent within the sacral ganglia and not the trigeminal ganglia. Not the trigeminal ganglia. So reactivation in this kind of person can cause recurrent ulcers. So I hope we are noting the manifestation of reactivation in these guys. Hello, people. Hello?
I'm sorry, what's the mechanism you mentioned?
So,
Dr. Babale, what mechanism did you make mention of?
For which one?
You said mechanism of reactivation. I'm asking what's the
No.
mechanism for
I said,
reactivation?
I hope you guys are noting the presentation for this reactivation, not the mechanism. The mechanism is just like they don't have any mechanism. They just stay within the sacral ganglia. Do you get it, Dr. Francois? So they stay within the cell bodies of the sacral ganglia. When they are reactivated, they move away from the cell body of the neurons. Then they move outwards to the skin. Do you get it? So that's it. So they move outwards to the skin and cause recurrent ulcers. So that's what I'm saying. So when you have reactivation, they have recurrent ulcers. Recurrent ulcer. The ulcers will not be bad. The ulcers for reactivation is not as bad as the primary infection. That primary infection is very, very severe compared to the reactivation. But when you are seeing somebody having recurrent ulcers, you are thinking maybe this is likely to be like it's reactivating. This neonatal herpes doesn't really cause any congenital malformation. You just be seeing the fetus having encephalitis, so there can be affectation of the brain. You see the vesicles within different area of the body. So it's not confined to the mouth or the genital. You just see it you can see it in the trunk, you can see it in the extremity, vesicles everywhere. Then the child can also suffer encephalitis, which will be shared with sluggishness and poor feeding. That's the spectrum for neonatal herpes. So they don't have the typical Orchidine teeth, or the mulberry molars, or the raggedies that you see in what condition?
Syphilis.
Congenital
Congenital
syphilis.
syphilis.
Syphilis, or the choroamnitis and chororetinitis, the microcephaly that you find in the other one. So you just find the typical lesion and the encephalitis. That's what they have. They don't cause any congenital malformation. No congenital malformation. So for the varicella, that's the one we call chickenpox. So varicella is the chickenpox aspect. Zoster is the shingles. Yeah, shingles is zoster. Chickenpox is varicella. So shingles is actually a reactivated form of chickenpox. So the primary infection causes chickenpox. The reactivation causes shingles. How do they get it? They can get it when they get exposed to the respiratory secretion. So somebody just sneezing, coughing around, they can inhale the droplet and get the infection, or they get in contact with the busted vesicles. The fluid from the busted vesicle can, touch another person and they can get. That's why they say that you can, get that infection by staying in contact with another person that have had the infection. So in addition to causing the typical varicella zoster rash, they can also cause encephalitis and pneumonia. So that's that about the varicella. You must always remember this. They can cause encephalitis and pneumonia, particularly in people that are immunosuppressed. They cause the encephalitis, they cause the pneumonia. Yeah, so how will the varicella present? So they typically have, the way the question is going to describe it is the baby, usually a young child, having the rash, at different stages. So they have the rash starting from the head, moving downwards, affecting the trunk, and it's going to be multiple rash at different evolutionary stages. So you have some of them at the Merkel stage, because it's going to progress from Merkel to the papule to the pustules to the vesicles. Then they will rupture as blisters. Then they'll crust and decay and they will break off. So that's it. The Merkel to the papule to the pustules to the vesicles. Then blisters. Then after they rupture, then they break off when they crust. So that's that about varicella. So once you see that, you see that there are different type of rash. You are seeing pustules, you are seeing vesicle, you are seeing all over the baby. You know that's likely to be chickenpox. That's likely to be chickenpox. It stays latent in two areas. So it can stay latent in dorsal root ganglion of the spinal cord, or stay latent in the trigeminal ganglia of the brain, of the head. So they don't stay in the sacral area. They stay in the trigeminal or the dorsal root. Now, when they are latent there and there's now immunosuppression, there's a reactivation. So that means it's going to come out from, let's say it's coming out from the dorsal root ganglion of the thorax. So it's going to move from the dorsal root ganglion to the skin. So you guys know that it's going to move from the ganglion at the spinal cord towards the side. So, oh my God, how do I explain what I want to say now? So you guys know that, okay, the spinal cord is in the middle. Please, can you guys picture that? Spinal cord is in the middle. You guys know that the ganglion is just at the side of each spinal cord. We have the right ganglion and the left ganglion. I hope you guys can picture what I'm saying. The ganglion on the right.
Okay.
Yeah.
Now, if there's a reactivation, it's going to move from that spinal cord in the middle to the peripheral, like outwards. So that means that there's no way it can cross to the midline. Do you guys get that? There's no way it can cross to the midline because it's moving outwards from the spinal cord. Can you guys? I don't know if you guys get what I'm saying. Hello? Let's see.
Can you do a schematic
Dr.
diagram? of it?
Babawale,
Yes, Dr.
the where it's coming from is along that sympathetic
cord.
chain, Abby.
The spinal cord. Yeah. So let me see. Okay. Yeah. So let's use this image. Let's use this image now. So this is what I'm trying to say. You know that this is a dorsal root ganglion on the right now. This for the left. Can you guys see this? Hello.
Mm-hmm.
So if it's up
It's not clickable, we can see one.
If I click on it, it's a video. I can't use it.
The screen is not okay. All right.
It's a video. See.
So, no, we can manage that one. At least we are seeing your cursor.
Can you see?
You've clicked on it again.
Wait, I'm trying to enlarge it. Oh, I can't even see the image. Don't worry, you'll get it. It's not something that is a big deal. Let me just manage that small what I have. Okay, let me just use this one. Let me use this one. What's wrong with my network again, for God's sake? Oh, okay. I think I know the problem. So can you guys see the image now? Can you guys see the image now? Hello?
Yeah.
Okay. So look at this one.
Yes.
Look at this. You can see this dorsal root ganglion here. You can see this. So, hello, can you see this?
Yeah.
This one. So that means that if the
Yes.
virus is, if the virus is staying here, so it's going to come outside. When it wants to reactivate, it's going to come outside like this towards the skin. You know that the skin is just by the side here. You know that this is where the skin is.
Mm-hmm.
So it's going to come outside towards the skin. So that means that this spinal cord is already in the midline. This one is the midline. You get this is the midline of the back. So it's going to cause the rash along the dermatome of this dorsal root ganglion. Let's say that this dorsal root ganglion is a dermatome of T4. So it's going to come like that and cause the rash, along that T4 axis towards the side of the body. Can you picture that, Dr. Juliet? So it's going to stop, it's just going to move at the back, or depending if it's the front or the back, it's just going to move like that from the spinal cord towards the side of the body. You get?
Okay.
That voice is not sounding like you get it. See, it's not hard. This is what I'm trying to say. Look at
like the dermatome of the placenta. Okay.
Look at this one now. You can see that this is the spinal cord in the middle. You know that this is spinal cord in the middle here.
Okay.
Now, the dorsal ganglion it will now move outwards from that dorsal ganglion like this. But it's not going to cross the midline because it will not, cross like this and start going like this and like this. No, it's just going to start from where it is coming from. You get? It's just going to start from where it's coming from there to go outward from there. You get? So in a dermatomal distribution, that is your shingles for you. So that is a presentation for the zoster. So when the primary infection,
so like the part I want to get there is that, like, is it that it's not crossing or what? Because I understand that, okay, as it's coming out from the dorsal roots, like it's going to follow the pattern of the dermatome. Like there's something you are trying to pass. There's a particular message you're trying to pass. I don't think I exactly got that.
Okay,
part of the message.
You know that this is the spinal cord here. Can you see my cursor? This is the spinal cord. This is where the spinal cord is. Now, it is coming from this dorsal ganglion within the spinal cord and moving outwards. It will not go like this and go to the left. It will not go to the left because if it goes to the left, that means that it has crossed the midline and it has gone to another ganglion. You get? So it will follow its own ganglion. That's what it will follow. The ganglion on that side. You get?
Okay, I get.
That is it. That's it. So, what I want to say now, you can only once you see disseminated shingles in somebody, you know that immunosuppression is mad. the person is heavily immunosuppressed. That is the only situation where you can see a bilateral or a disseminated shingles that you have both sides is bilateral, affecting both dermatome like on one plane. That's crazy. So it typically affects the dorsal root of the spinal cord, and you know that the spinal cord runs from the cervical region to the sacral region. So it can move anywhere from the chest down to the stomach. You get, depending on the segment of the spinal cord that is affected. Do you guys understand for the dorsal root? Hello?
Yeah.
All right. So, but most commonly we see it at the thorax. The thorax, that's where it affects. Then it can also reactivate and stay latent at the trigeminal ganglia. So that means that if it's going to reactivate, it's going to affect the side of the face, because you know that trigeminal nerve confers, sensory supply to the face. Abi, now you guys know that. Abi, the
Yeah.
ophthalmic, the mandibular, and the
Yeah.
The maxilla, the plan, yeah.
So the ophthalmic one is the most commonly affected one. So it's going to cause epizoster ophthalmicus. You get. So it's just going to affect the forehead, the upper part of the um, ophthalmicus. So let's see if we can see the image for what it looks like. So that is when the reactivation is coming from the trigeminal ganglia. I was thinking we're able to finish this, but so this is it. Can we see this? So this is the epizoster ophthalmicus. You guys can see that it's not crossing the midline. You can see that it's
Yes.
just in the hair. So that is epizoster ophthalmicus. Reactivation of chickenpox in someone that has previous chickenpox now developing shingles. So that's the way it presents. Now, what is the complication of shingles? The most common complication of shingles is post-epitic neuralgia. So now, sorry guys, before I leave, so I said that is the ophthalmic branch. So that's the V1 branch. Don't forget to, please. The common branch that's affected is the ophthalmic branch, not V2, not V3, V1. Ophthalmicus.
All right.
So what do I want to say? So the most common complication of shingles. So after all this rash have happened, the most common complication is post-epitic neuralgia. So after all the rash has gone, you'll still be having some pain, some burning, itching pain at that area where that rash, was before. So that is what we call post-epitic neuralgia. So don't forget. So most common complication for herpes simplex virus 2, particularly after reactivation, is what? Anybody?
Most what do you call it now?
Most common complication after following reactivation of herpes simplex virus 2.
You said post-hepatic neuralgia now.
No, 2. Herpes simplex virus 2.
Reactivation?
Yeah, so when there's reactivation for herpes simplex virus 2, what do you expect? What do you see?
Epizoster ophthalmicus.
Recurrent ulcers.
Recurrent ulcers. You guys are not paying attention. I'm not happy. Oh God.
No, because you said common complication. Common complication of
I said
HSV2
I said
is
two.
Okay, so
the
one is
reactivation
labial
is
leaf,
recurrent
2 is
ulcer.
recurrent ulcers. Okay,
Yes.
sorry.
So what's the that of 3 now?
3 is this one that I just mentioned,
is,
post-hepatic neuralgia.
neuralgia.
Okay. So Epstein-Barr, we said the mode of transmission for Epstein-Barr is just the same as herpes simplex virus 1. Respiratory secretion and saliva. People that are kissing, so that's why they call it kissing disease. So what you want to watch out for Epstein-Barr is infectious mononucleosis. Very high yield. How would they present? There's fever, there's sore throat, there's lymphadenopathy, particularly affecting the posterior cervical lymph nodes. There's hepatosplenomegaly. If you have not mentioned this hepatomegaly, you have not said anything. Hepatosplenomegaly must be part of the presentation for infectious mononucleosis. It's an infection, there's going to be fever. Infections are shared with lymphadenopathy, but this one particularly affects the posterior cervical nodes. There's going to be a sore throat because, of course, transmitted through the respiratory tract, and there is hepatosplenomegaly. One thing they want to say, but maybe I don't know if they can ask that in step 1, but you must always be careful for the risk of splenic rupture because of the hepatosplenomegaly. So you want to avoid heavy exercise or sports that can lead to abdominal trauma, which can cause splenic rupture in these guys because of the splenomegaly. So aside causing infectious mononucleosis, what are the other things that Epstein-Barr can cause? It can cause malignancy, very important. It can cause lymphoproliferative disease like Hodgkin lymphoma, particularly in people that have received transplant. So it can cause Hodgkin lymphoma and all those things. It can cause some other lymphoma like Burkitt lymphoma. in endemic regions like Africa, Burkitt lymphoma, Epstein-Barr is implicated. Epstein-Barr can also cause nasopharyngeal carcinoma. So once you see a patient having a nasopharyngeal mass, you check the nasopharynx, you are seeing mass. It is only Epstein-Barr that can cause that. Very high yield. And it's very common in Asia. If you want to know that, it's good. But once you are seeing someone that's having Burkitt lymphoma, mass within the jaw, Epstein-Barr is implicated. So people having lymphoproliferative disease like Hodgkin lymphoma, primary CNS lymphoma, and all those things, Epstein-Barr is also implicated. So how does Epstein-Barr does its own stuff? It infects the B cells. That's what it attacks. It has predilection for attacking the B cells. So how does it attack these B cells? It binds to the CD21 receptors on the B cell. So it has CD21 receptor that can bind to the CD21 cluster differentiation on the B cells. That's why it attacks CD21. Don't forget. B cells have so many things that defines it. CD19 is one of them, 2021. So the 21 component is for Epstein-Barr. That's what it attacks. In response to the infection of the B cells, the T lymphocyte will try to assist. And there's going to be a reactive lymphocytosis. There's going to be reactive differentiation of the T lymphocyte to attack those infected B cells so that it can take them away. We call them atypical lymphocytes because they become abnormally shaped. So they become enlarged and they are irregular. So they don't look like the typical T lymphocyte. So this is what we have here. I think that should be image G. Yeah. But it's not looking at the typical one that we have. So this is it. So they are trying to show us the normal and the abnormal one. Yeah. So I think these ones by the side.
Is it also the Downing cell?
The what?
Also called those Downing cell.
No, I don't know the other name. Did you see it somewhere?
Okay. Yes.
Yeah, so most of the time they won't call it any other name to be straightforward. So they call them atypical T cells. So they just appear enlarged and they look irregular. So their nucleus is not well defined. So you just see the nucleus is regular and they are bigger than the typical, T lymphocyte. So the one that form the atypical cells are the T lymphocyte, but the cells that are affected are the B cells. So we must get the difference so that we don't get confused when we see the question. Ones that react to it and they'll be atypical are the T cells. The ones that are infected are the B cells. Yeah. So how do we identify them? So if you do a blood smear, in addition to having the features of infectious mononucleosis, if you do a blood smear and see your atypical lymphocyte, you can almost always make your diagnosis of Epstein-Barr virus infection. So how do you diagnose it? You can also use this positive monospot test that we talked about, the heterophile antibody detection. So because people with Epstein-Barr can have those antibodies against this all cell, red blood cell, or sheep antigens. So they only have those antibodies in them so that they can agglutinate the sheep or the horse red blood cell. We've talked about this. So the only one that is positive for the monospot is Epstein-Barr. Don't forget Epstein-Barr. CMV is negative. Which other infection did we say is also negative for monospot? I know that it's not easy, but do you have anybody that can remember? We're talking about it then. We said that parasite is also negative for monospot. Anybody? Okay.
So it's negative for what?
For monospot.
Negative for what?
Monospot. Okay, so that is Toxoplasma gondii. That is Toxoplasma gondii. Yeah.
The heterophile is the one that you said is negative for is negative for that's the Toxoplasma. Is it the same thing as monospot?
Yes, monospot or heterophile antibody test. That's Toxoplasma gondii. So if because of the strep throat that they have, because of the sore throat rather that they have, some people might want to use amoxicillin to take care of this sore throat. Thinking is maybe from streptococcus. If you give them amoxicillin, there's a high chance of them developing maculopapular rash. So that can also help you with the diagnosis. If they say that okay, the person was given
Dr. Babali, Dr. Babali.
I'm listening, Dr.
Like this, because I remember when we were doing. Okay, Because when we're doing toxoplasma gondii, I thought you said the other one was positive and CMV was negative. Now you're saying that the other one that is also negative is toxo.
No, no, Dr. Julia. If you remember that day, Dr. Adeola was asking me, is it only Epstein-Barr that was positive? No, that was the agreement. It is only Epstein-Barr that is positive. And that was why she was asking me that day that, is it only Epstein-Barr that was positive? And I said, I'm not sure, but most of the time they say that
Okay, so toxo is negative. Okay.
toxo is negative.
Okay,
Toxo is
negative.
cytomegalovirus. So this one has so many routes where how you can get it. It can be transmitted congenitally, transfusion, sexual contact, saliva, urine, transplant. So it's that's why when you want to transfuse blood, part of what they screen for is cytomegalovirus. You can get it from, mother to child can transmit it. That's why you can have the congenital CMV infection. You can get it through sexual contact, saliva exchange, urine, and people with organs infected with cytomegalovirus, because cytomegalovirus can affect so many organs. So if you get organ that is infected with cytomegalovirus, the person can also develop that infection. So what is that about cytomegalovirus? It can also cause mononucleosis, just like Epstein-Barr. And what you can use to separate them is that once you see the question presenting this history like this, and they are saying monospot is negative, they are already guiding you to answer. Most of the time, it will be cytomegalovirus. It will be cytomegalovirus because toxo too has a negative monospot test, but it will not cause mononucleosis. It will not cause fever, hepatomegaly, pharyngitis, and all these things. So once you are saying your fevers, lymphadenopathy, hepatosplenomegaly, sore throat, you know that that's likely to be infectious mononucleosis. And they did the monospotted is negative, so CMV is your answer. CMV is very common in people that are immunocompromised because once CMV infects somebody, they tend to stay latent within the mononuclear cells, the monocytes. That's where they stay. They stay latent in the monocytes. So when there's a background immunosuppression, they come out and they cause very serious disseminated infection. So just think of any organ, toxo can affect it. So most of the time, they will talk about CMV retinitis. So once you see somebody having HIV/AIDS and you are seeing the person having retinitis, please, one organism that you have at the back of your mind first is CMV. Don't even be thinking diabetes or hypertension. CMV should come to your mind first. Look at the question and make your diagnosis. So on fundoscopy, there's going to be hemorrhage, the cotton wool exudate, which you can have.
Chororetinitis.
Yeah, so they can have co-retinitis. So CMV retinitis, I don't think it's more. I think I've always known it to be retinitis. I don't think it affects
Okay.
the middle layer, but maybe it can spread to it. But it's retinitis as you are going to have retinal hemorrhage, edema of the retina, cotton wool exudate, and vision loss at the end. So don't forget, don't get confused with the cotton wool exudate. That cotton wool exudate can also be seen in someone that has diabetes or hypertension. But what is just there is that, in the setting of someone that's having AIDS, so you might not be thinking of hypertension or diabetes, that kind of person, and they will have given you some other clinchers that you can use to make diagnosis of your CMV. So your CMV can cause retinitis, it can cause hepatitis. So once you see someone having AIDS and having deranged liver parameters, AST level over the roof, ALT over the roof, you are thinking of CMV hepatitis. It can go to the esophagus and cause esophagitis. And CNC esophagitis is going to cause linear ulcers, just like we talked about. It goes to the lung and cause pneumonia. So it's part of those viruses that cause atypical pneumonia, CMV. So pneumonia, esophagitis, hepatitis, retinitis, even colitis. Someone having AIDS, having inflammation of the colon. You are thinking of CMV. I don't know why they didn't put it here. Very important. CMV colitis, CMV esophagitis, CMV retinitis, CMV hepatitis.
So they
CMV
didn't put the
retinitis.
colitis and the hepatitis and these things that are listed.
Yeah, it's not here.
They
So
didn't list the hepatitis and the colitis with this.
yes, they didn't list it, but it's there. It's there. Don't forget. So the way you can detect CMV is by doing your biopsy. So you're going to see whole high inclusions. So that's the typical presentation. You're going to see once you see the whole high inclusion, so something that is looking like a whole high. Can you guys see this? So you can see that it's bilateral you know.
Mhm.
Yeah, so once you see this high intranuclear diffusion, it's your CMV straight up. CMV. All right. So let's just round up with these two. Human herpes simplex virus 6 and 7, both of them cause the same thing. They cause roseola fever. So it's transmitted through the saliva. What I just mentioned about this roseola fever, they will say it that this person is having high fevers. So the baby will be having very terrible fever that is extremely high. This fever can get as high as 40 degrees Celsius, hypothermia. And the rash will now, that fever can last for like 3 to 5 days. Because of that high fever, the child is going to suffer fever convulsion. The child starts convulsing. Then after the convulsion or the fever later subside and the macular rash starts appearing. So they are centrifugal in their distribution. They start on the trunk and they move to the extremities. So once you are seeing a history of someone that has fever, high grade, maybe the person convulsed, then subsequently the fever came down and the rash appeared almost immediately. And they were starting from the trunk moving to the extremity. You are thinking of roseola, which can be caused by HHV 6 and 7, but most commonly 7. Most commonly 6, rather. Most commonly 6. So that is that about roseola. It's very common in people that are younger than 2 years. Yeah. So the last one is human herpes virus 8. That is Kaposi sarcoma. It's transmitted sexually. Sexually, don't forget that sexually. Kaposi sarcoma. So Kaposi sarcoma is neoplasm of the endothelial cells, particularly endothelial cells of the lymphatics. That's where it affects. So it's very common in people that have HIV/AIDS or people that are immunosuppressed or maybe transplant. Don't forget, once you are seeing Kaposi, it's like that person has AIDS. Very important. So that virus is going to thrive within the endothelial cells of the lymphatics and cause abnormal proliferation of those endothelial cells, and they will appear as dark volaceous plaque or nodules. So I think we have an image here. So this is an image of this is the image for the roseola. You might not be able to make the diagnosis from the picture, but from the history, you'll be able to clinch that diagnosis for roseola. So don't really bother yourself about how it looks like. But if you want to know, you can do more research. This is okay. So what is this? What is this image E? Anybody? What is this image E?
Shingles.
Yeah, so this is shingles. Yeah. So this image C should be the
Yeah.
um
Yeah.
eh? Is that
And
which
so
image?
because that wasn't like the dermatoma area that
Yeah, you can see that it's very close to the armpit. Yeah, so image C should be the neonatal congenital herpes. You can see the vesicles within the legs.
happens the vesicles.
You can see that this is not the typical area
This
where
is looking like it's on the stone
yeah,
of the
this
foot.
is stole. You can see that this is not the typical area where you're supposed to see the vesicles. We said it. That you not see it in
Mm-hmm.
the typical area like genitals or the mouth. You can see it widespread in the body. So once you are seeing this, you are thinking of congenital herpes in somebody. So that is that. Then this is a Kaposi sarcoma, abnormal proliferation of the endothelial cells in the lymphatics, causing this dark purple-like papular or nodular lesion. If you do the biopsy, you are going to see lymphocytes there. That can help you separate it from someone that has bacillary angiomatosis. Both of them are common in people that are immunosuppressed. Don't forget. One is caused by an infection from a bacteria, bacillary angiomatosis, Bartonella what? Enseli. While the other one is caused by a virus, which is the human herpes type 8, Kaposi sarcoma virus.
This is sarcoma. But you said this one, when we check this one, you see lymphocyte, Abby.
You see lymphocytes. When you check the
This
bacillary
lymphocyte.
angiomatosis, you are going to see neutrophils. So, in addition to the fact that Kaposi sarcoma can happen in the skin, you can also see it in the GIT and the lungs. So, someone that have it in the lungs, because they are vascular lesions, they can rupture, and this person can present with hemoptysis. So, they can affect the GIT and cause obstruction of the GIT lumen, leading to intestinal obstruction. They can also rupture and they can cause diarrhea that is bloody. So that's that about Kaposi sarcoma. So do you have any question? Call it a day so that we can prepare for the next.
Yeah, I have a question.
Okay.
How can you distinguish? Yeah, how can you distinguish the rash of HHV 6 and 7, the Roseola infantum from measles.
From measles. Okay. Most of the time, the way they will, tell you, it's more like the presentation. So measles will start from the head. Measles will start from the head, unlike your Roseola that will start from the trunk and go to the extremity. Although both of them are like centrifugal, but measles will start it from the head. It doesn't start from the extremity. It doesn't start from the trunk, rather. It starts from the head and moves downward. Then there's going to be some associations that you see with measles that will help you make a diagnosis, which includes the C's, the coryza, there's going to be running nose. You see the Koplik spot in the mouth. Then there will be this characteristic movement of the rash coming from the head, then downwards to the trunk and the extremity. So I think that's that about measles. So once you are saying, coryza, you are saying cough, you are saying the Koplik spot afterwards in the mouth, and you are seeing the typical pattern of distribution of the heart rash starting from the head, moving downwards. That's likely to be measles. So we are still going to talk about measles because measles is one of those RNA virus. So we are going to talk about it when we get it.
Okay, thank you.
Yeah, you're welcome.
I have a question. Dr. Bari, the
Mhm.
erythema multiforme, is it the same thing as okay? Is it the same thing as the erythema multiforme?
Erythema what?
Are they the same?
No, I can't.
Multiforme
And
and
what?
the erythema multiforme.
No. Erythema
Don't worry.
Hmm?
Don't worry. Don't worry.
Erythema. I should not worry.
Like the way he has it.
No.
Like,
See, I'm not criticizing you for asking the question. I'm just hearing what you are saying. I can't hear what you are saying. That's what I'm saying here.
oh, okay.
Yeah. So erythema nodosum is inflammation of the fat. So it's more like a paniculitis. So it typically affect the shin. You get it's shin, the shin. That's where it affects, and they appear nodular. Although if you look at the picture, it will look like a macu, but it's actually like nodule. That's why they call it nodosum. So they are kind of raised, and they are nodular, and they are very tender and painful. Unlike original erythema, um, which one did you say now? Erythema
Multiforme.
multiforme. Yeah, erythema multiforme will start like a red patch that will now progress later to form target lesion. You get, and in most situation, erythema multiforme follows some specified infection, like someone that has mycoplasma pneumoniae, someone that has like HSV type 1, someone that is using some medications. So someone that is using medication, you can have erythema multiforme. But erythema nodosum, they typically use it, okay, like someone that has this guy now, what's the name of this celiac disease? No, it's not celiac disease. I'm trying to remember. This there's this particular infection. I've forgotten now, but they can put it with all these. Sorry, they can put it with the fungal infection like histoplasma. Thank you, histoplasma, blastomycosis, erythema nodosum is there, or they can put it with someone that has Behcet disease. So, yeah, but one thing that will always give erythema nodosum away is that you see it, it will look dark, it will look flat, and sometimes raised like a nodule, and they will tell you it's nodular, and they will tell you that it's tender. Once you are seeing that it's tender, and it's now located in the anterior aspect of the leg, the shin. That's the erythema nodosum. So if they tell you the pathophysiology, if they ask you pathophysiology, it's due to inflammation of the fat. That's it. All right.
Thank you.
Okay, guys. So
Thank you.
we'll call it a day. Then we'll continue later.